All right. You all tired yet? No? All right. I'll make you tired. I'm just kidding. So my name's Daniel Claassen. I'm a neurologist. I'm at Nashville, Tennessee. And I just wanted to let you know that I'm missing the Georgia-Tennessee game right now to talk to you. That's how important you are to me. All right? So how about them Bulldogs? I'll tell you a funny story, actually. This isn't the first time I've met folks from San Francisco who have an interest in MSA. When I was a resident, I published this paper on MSA and brain imaging, and I got the most amazing email from the support group here in San Francisco asking these very difficult questions about my paper. And I said to them, I wish you all had reviewed this, because these are very good questions. So it's good to be back. And we also looked at some of these questions you all put in before this meeting, and they're very, very good questions. So hopefully we can cover some of them through this lecture. So I have a task of taking you through clinical trials. How many people have been involved in a clinical trial? Any trial, any clinical trial. All right, so our goal at the end of this day is to increase the number of hands. All right? Clinical trials are how we advance therapy. All right? So at the end of this lecture, I have two goals. One is so you know what clinical trials are. You know the the verbiage for them. You be able to understand what they're doing. And two, just give you kind of a picture of what's going on, what's exciting right now in MSA. It's not everything. There's just some things that, for the sake of time, I picked as important. And maybe you can keep your eyes open for some clinical trials that come up sooner than later. All right. So what do we need? We need a cure for this disease, right? We need a cure for it. Everyone agrees that that's our overarching goal. But that's kind of, it's a hard thing to find a cure for neurologic diseases, right? Oh, no one needs to listen to this. I mean, you can listen to me. Slides are not that important. So we need a cure. But, what's interesting is that I've sat around some tables to talk about people about their MSA. And the thing that I find over and over again is everyone's got a different story. Everyone has a different clinical presentation. The first symptom that one person has is very different from another person. So if you think about it, if you think about how to design a trial to find a cure for MSA, it does present a little bit of a challenge when not everyone's acting the same way, or the symptoms that people have are a little different. So that's one challenge that we can overcome. We just have to come up with creative ways to do it. It's not like having pneumonia from a bacteria, and I can find out the bacteria, see if the antibiotic works, give you the antibiotic, and see if you get better. It's not that easy. It's a little bit more challenging, right? There's a lot of different things that can happen between people with, whether they exercise or not, or what their first symptom is, etc. And then, why does it progress differently? I think someone mentioned earlier today, they talked about a patient they had who they've been following for 10, 15 years with an MSA diagnosis, whereas other folks become a lot more severely incapacitated a lot sooner. So we know that it presents differently, progresses differently, and that presents another challenge, right? If you're going to design a study where you have an intervention that can slow the progression of the disease, and some people are progressing faster than others, it's kind of hard to figure out, well, did we really slow it down, or did we just have a bunch of people in one group that were slow progressors? It's a hard thing. And what makes it so heterogeneous? What is the biologic basis for why a person gets, say, REM sleep behavior like Mitch talked about, or some person gets first autonomic dysfunction? What makes it heterogeneous? So those are important things. So we've got to figure those out to come up with good clinical trials. And we need better treatments. How many people are satisfied with their treatments for MSA? No hands, right? So we need better treatments for therapy. So we find a cure, we need better treatments, so those are kind of the big pictures about clinical trials I'm going to go over. So what's a biomarker? I'm going to teach you what that is, because that turns out to be important when we try and answer these questions. And how do we measure outcomes? That also turns out to be important in how we answer these questions. So a biomarker is some way to objectively identify the medical state of a person outside of that patient. Does that sound complicated? So a biomarker is simply, can I come up with a quantitative measure of how bad your disease is? That doesn't necessarily rely on, certain things about you. Like if you had a blood draw, you got a protein, you said the protein level is 4, therefore this person's disease is X. That would be a nice biomarker, right? So We certainly got some clinical biomarkers that are okay. So I can maybe give you a questionnaire, or give your care partner a questionnaire, and ask them questions about, can you walk? How do you sleep at night? You're having a hard time using your knife and fork? And I can create a total score, and it can give me some estimate for how severe your symptoms are. That's generally okay. There are these biofluid biomarkers, right? So I can do a blood test, or I can do a spinal tap, right? That's a real popular one, because all the fluid that surrounds your brain goes all the way down your spinal cord, and I can put a needle in your back and draw some of that fluid and get an estimation for what's going on in your brain. That's a really attractive biomarker, biofluid biomarker. And then I can do imaging, MRI scans, PET scans, and I can take that image and maybe quantitate it a certain way to get an estimate for how severe your disease is. So biomarkers are important. They're important not only to figure out progression, but if you can imagine a therapy that may work for MSA, you could have that biomarker be the endpoint for a trial. I'm going to talk about endpoints in a second. So if you can change the biomarker, accept the heterogeneity of patients in terms of their symptoms, you might be able to find a way to change the disease course. So when we talk about outcome measures, we're talking about how do we estimate the effectiveness of a therapy, right? So we usually, in clinical trials, you have what's called a primary outcome measure and then a secondary outcome measure. So your primary one is, I'm doing this study to see if this happens, right? Because you could throw a whole bunch of outcome measures in a bunch of patients and by chance happen to see something, right? Like the classic example is the studies on chocolate and health, right? Of course chocolate is good, but everyone will come up with, well, chocolate reduces your risk of heart disease. Really? Because you measure heart disease, sleep, and all this other stuff, and it turns out to be significant. But so it turns out that for a trial to be done properly, the person designing the trial has to say, I think this is going to happen, and this is why I'm doing this trial. And I'm going to test this by doing this study, right? And then you can have secondary outcome measures, so other things that you're interested in. So for instance, in MSA it may be, I'm using this medication to see if I can slow the progression. My primary outcome measure is going to be time to wheelchair needs, right? How long does it take before a person goes from walking to a wheelchair? That may be a reasonable primary outcome measure. But then I can also look at maybe the MRI changes in the brain, or the CSF amount of Alpha-Synuclein. Not that that's a great one. That's been a challenge. Just ask Kathleen. She knows all about this. And other things like that. So that's an example of when you do a trial, you'll kind of see these different kind of endpoints. The other big term I want you to think about is inclusion and exclusion criteria. This is really where the rubber hits the road for people that are enrolling in clinical trials. So who is the right patient for this study, right? Not every study is right for every patient. For instance, if you think that your intervention is going to help patients with early symptoms of MSA, you may be specific to say, I want people diagnosed with MSA, but can only have symptoms for at least 3 years, right? So you've got an inclusion criteria, which is you have to have MSA, and have an exclusion criteria, but you got to have it less than 3 years of symptoms, no longer. So when you look at clinical trials that may or may not be important for you, that's one way to kind of see what the trial is trying to assess and kind of get in behind the mind of the person who designed the trial, or the people who designed the trial, to understand what they're kind of looking at. And as a carer or as a patient, it's really useful to know whether or not this trial is right for you. And not every trial is right for every patient. So that's kind of at a key point. So when we think about studies, the different types of clinical trials, you've heard about observational studies, right? Just observing how you're doing. Maybe there's cross-sectional. I'm going to look at 100 patients with MSA and just look at them one time. And then we start thinking about intervention. So phase one, we kind of get away from these terms now, but generally they still hold up. Phase one is a study where, is this safe? Is what I give you safe for you, or is it going to hurt you, right? Sometimes those are done in healthy people, i.e. people that don't have neurologic problems. Sometimes they're done in patients as well. because sometimes you want to do a study and see if it's safe in patients and also potentially see if it's doing what you think it's going to do. A phase 2 study is really kind of an early target validation efficacy study. Is this intervention doing something? Can I see a signal? And if I do see that, can I go to a phase 3 study where I can say I'm going to now randomize patients to this medication or this intervention and actually definitively tell, is my primary outcome going to be successful? And then once the drug gets approved, then there are these phase 4 studies that can be done later to kind of look at other questions. So you need a good phase 3 study or a pivotal study to get approval, at least in the United States, for FDA approval. So I'm going to just overview, this is kind of the trials that I'm going to talk about quickly. Again, they're not comprehensive, there are other trials going on, but these are the ones that tend to come up a lot in discussions. Hopefully give you some encouragement to know that people are doing work to try and find cures. Hopefully give you some insights as to what may come in the future and maybe get you more active in clinical trials. So I'm going to talk about stem cell therapy first, Alpha-Synuclein, which you've heard about a lot. Yeah, you can go home to your next cocktail party and use the word Alpha-Synuclein and people look at you funny. You sound really clever. Norepinephrine and then iron. So my good friend Wolfgang Singer, he and I were in residency together. He's at Mayo Clinic. He's done some really interesting studies with stem cells. Intrathecal administration of autologous mesenchymal stem cells sounds like a mouthful. Essentially is, if I inject stem cells into your lumbar area like a spinal tap, and I get those stem cells maybe from your own body, right? They're not like fetal stem cells or embryonic stem cells. Can I change the course of MSA, right? And so he has done a study where he's done a phase 1 safety, and 2, does it hit the target escalation study in some patients. So he looked at 8 patients who got a single dose, 8 patients got 2 doses of one amount, and 8 patients who got 2 doses of another amount. And he looked at these folks for 12 months. So his inclusion criteria were patients who had MSA P or MSA C. Remember those 2 terms from earlier today, Parkinsonian versus cerebellar MSA. And they had to have some evidence of autonomic dysfunction. And they had to be an early disease state. And there's this UMSARS, that's another word you can put in your vocabulary, is just a rating scale for how bad your MSA is. And his main outcome measure was to determine the safety and tolerability. See how these are designed? It's not that hard. It's pretty simple, right? So your primary outcome measure is he's going to determine safety and tolerability. And then his secondary outcome is to look at disease progression. And he was going to compare it to a group of patients who had previously finished the study using rifampicin. So he has some nice data on looking at estimated rates of change in this population. He was going to look at his population versus that one. And then he was going to look at autonomic function using some rating scales. And then look at the cerebral spinal fluid to see if any of these markers were changing. So in this 24-patient study, he didn't see any serious adverse events. He saw some. So a couple of people had a little fever. A number of people had, when they did MRIs of the lumbar spine, they found some thickening of some of the nerve roots. And he had, with the company, with some basically some tingling in the leg. And so the safety conclusion was, remember that's a primary outcome, safety study, phase 1, was that it's safe. There is some potential for a person to have some low back pain, maybe from what's going on in those nerve roots, and it seems like something that may be interesting to go forward in another trial. And I'm not going to go through all these graphs in too detail, but essentially what he showed is that UMSARS, that rating scale for MSA, showed at least a suggestion of changes between the different dosing. And he also looked at spinal fluid levels of this compound called NGF and showed that before and after intrathecal administration of these stem cells, that these NGF levels were changing. So that gave him optimism to go forward in a future trial to see if this therapy could help patients. And so he's now planning that for a future trial. So you might see in the future, and hopefully in the near future, a larger number of sites doing these autologous stem cells to try and change the disease progress. We get a lot of questions of stem cells, but this is probably, in my opinion, one of the more advanced in terms of where we are going into the next stage of clinical trials. All right, so you've heard a lot about alpha-synuclein, and of course this is an interesting protein that is involved in MSA amongst other diseases like Parkinson's disease and Lewy body dementia. And certainly there are a lot of people that are interested in modulating alpha-synuclein. So an autopsy sample, if you look under the microscope, you'll see these little alpha-synuclein clumps, and we call them Lewy bodies after the neurologist, or I don't know if it was a neurologist, but pathologist, Dr. Lewy, that discovered these. And so that's why we call them Lewy bodies. That's for your next Trivia Pursuit game. But the idea is if you can stop these Lewy body clumps from happening, could you potentially prevent the disease from progressing? Could you halt it where it is? And that's an attractive idea. They're definitely involved in disease because we can see them in tissue. We know that there are certain clinical symptoms that really make you think that there's alpha-synuclein, like REM sleep behavior, like autonomic dysfunction. So could you perhaps guide a therapy in a population that has some symptoms of alpha-synuclein and modulate it to maybe prevent the accumulation of alpha-synuclein clumps in patients? And it's a very attractive idea, and there's a lot of people trying to do this now in different ways. One of the most kind of close to prime time ways that this is happening is through immunoglobulin therapies. And so essentially the idea is you make an antibody like you would an antibody to, say, a virus or an antibody to some kind of pathogen, but instead of taking out a bacteria, you take out alpha-synuclein. So can you make an antibody to the alpha-synuclein aggregate and give it to somebody, and then make the body treat that alpha-synuclein like a foreign invader, and then pull it out of the brain or pull it out of wherever it needs to come out? So it sounds like it's very attractive. And this is not the first time that this therapy has been done, because it's been done for amyloid. You've heard of all those trials for amyloid and Alzheimer's disease. Similar idea. It's been done for tau, another protein that turns out to be important in neurodegeneration. And so now it's reasonable to look at this in alpha-synuclein, and there's a couple ways that you could do this. So usually what happens is in these trials, you get an intravenous therapy, which means you get an IV. You kind of hook up to a bag, and they give you the immunoglobulin, and about 1% to 2% of it goes across the blood-brain barrier, and it goes into the brain or the central nervous system, and then the hope is that it'll change the way the disease progresses. So I think in MSA, it's certainly reasonable to think that there may be a trial that involves immunoglobulin therapy for alpha-synuclein, and to see if it changes the disease course. And so I would keep your eyes open for one of those, perhaps, because I think that would be a very interesting therapy. It's going on in Parkinson's right now, so it's not unreasonable to expect it to maybe for MSA. So now I'm going to shift a little bit to therapy, because that's another important thing that we need clinical trials for. Can we improve the symptoms of patients who suffer from MSA? And one of the more attractive therapies has to do with this neurotransmitter called norepinephrine. Anyone heard of norepinephrine? I'm giving you all these 7-syllable words today. I apologize. I should make it simple. But this is the neurotransmitter that kind of gives you the up and go, right? It's important in your blood pressure. When you stand up, your norepinephrine gets released. You need it for it to stay active, not to be tired, right? So you need it for blood pressure control. And so it turns out that this is important. And we've got some norepinephrine medications now that are on the market. So droxidopa is a medicine that is related to norepinephrine. Midodrine kind of stimulates the same receptors as norepinephrine. So it's not the first time we've thought about this. So it turns out that there are some medications that might actually change norepinephrine levels in the brain. Here's an example of one, atomoxetine, which was used for ADHD in some patients. Turns out can change norepinephrine levels. And one of my colleagues at Vanderbilt, along with some of our friends at NYU, are doing studies on this medication to increase norepinephrine levels in the brain. It turns out that if you give a patient atomoxetine, a norepinephrine reuptake inhibitor, so what happens there is if you give this medication, the brain doesn't recycle norepinephrine like it should. It stays out there, so it increases the levels. And it turns out it modulates blood pressure. And it has a central effect, meaning it's acting in the brain and not the periphery, so it has an attractive therapeutic option for patients. And I've talked about droxidopa. There's a very exciting press release that just came from a company called Theravance, who's here. You can talk to them. It talks about a medication, TD9855. I'm sure they'll change the name. I don't see that one. But it's a medication that modulates norepinephrine, and it does a little bit of serotonin as well, apparently. But it might be able to improve a patient's symptoms of NOH. And so I want to take you through an example of a study where if you were a scientist or a physician or someone who wanted to design a trial, you can kind of think of what would that trial, how would I test whether or not this medicine works or not, just so you can start thinking critically about how to interpret trials, how to interpret press releases, how to interpret whether or not the trial is interesting to you or not. So here's a hypothesis. I'm going to say, in this case, I'm going to give you a norepinephrine transporter blocker, in this case atomoxetine, and I'm going to say that if I do this, I think it's going to improve your symptoms, and I'm going to give it to people that have a disease called pure autonomic failure, a primary autonomic failure. So my inclusion criteria, right? Who are the people I want in this trial? Well, I'm going to have people, generally speaking, when I see primary autonomic failure, they're about 40, sometimes they're a little older, so I'll have 40 to 80. If I go above 80, may have some potential issues, so I'm going to cut it off there, right? They're going to have to have autonomic failure. I'm going to define that by a blood pressure reduction. So I've got to have at least 30 millimeters of mercury drop with blood pressure changes withstanding, right? My inclusion criteria could be, well, if a person's tried atomoxetine and had a bad reaction, probably not a great person for that trial, right? So I might exclude people who have hypersensitivity to it. If they're on a medicine that might compete with this, another norepinephrine, I might want to exclude them as well. And if they've got some things like heart failure, or maybe they've got kidney problems or some other issue like glaucoma, which we know could get worse, I want to exclude that. So you see how we're thinking about these trials, how you're designing the population that you want to treat, right? So I'll come up with a flow. In this case, this was the atomoxetine study. So patients get screened, make sure they're the right patient. They would test a couple doses to optimize the dose, and then they would switch them from either getting a sugar pill or atomoxetine and then flipping it over to the other one to kind of see whether or not a patient responds on one therapy or doesn't respond on the sugar pill. And this is a convenient way to do studies where, because each patient is different, you have within subject testing, right? Because one patient may respond differently than another patient, and so you're actually able to see the response of the patient to the intervention, in this case atomoxetine versus the placebo in the same study. So it's an attractive way to do it. And so if you sign up for this trial, you may have to get a physical from a neurologist or a medical doctor. You might have to get some blood tests like a CBC, a complete blood count, or a metabolic profile. There may be some other screening tests to make sure you're not pregnant or you don't have urinary tract infection, which might alter your blood pressure. You may have to get some tests like autonomic function tests, orthostatic tests. So you come in for screening part of these clinical trials. There's a bunch of things that happen. And then you may get you're going to get 2 test doses to see what you respond to, and then you get randomized. You're going to get in this case it was a 9-week treatment, and you would get some assessments. So this is an example of a clinical trial. So if you're signing up for a clinical trial like you're going to after this, right, you're going to get with your centers, you're going to say, we need more clinical trials. These are the kind of things that you'll go through in a consent process, and now you can understand a little bit more about how these trials are made. So that's an example of a treatment. So the last thing I want to talk about is a really intriguing aspect of disease that I've become more familiar with recently, and it's the issue of this iron and how iron might relate to the susceptibility and progression of neurodegenerative disease. So it turns out that the older you get, the more iron you have in your brain. Not sure why that's the case, but that's what's been shown over and over again. And that might be because when you get older, your blood-brain barrier changes a little bit in permeability. You may be susceptible to some inflammation that you didn't get when you were younger. There may be redistribution. There may be changes in how your body handles iron. But we know that there are certain areas of the brain that when you get older, you see more iron. And they are very intriguing to diseases like MSA because they seem to relate to it, right? The substantia nigra, that's the part of the brain that makes dopamine, that seems to get more iron. The subthalamic nucleus, also one of these basal ganglia structures, gets it. The red nucleus, which is part of this Mickey Mouse here, this person's lying on the table and you've cut through and you can see this big thing here is the red nucleus right here. I don't know if my thing's coming, it's not on there. This thing right here, red nucleus right there. It's not red, but it's what they call it. And then and then you got all these other areas like the putamen, caudate nucleus, globus pallidus. They all have iron. So why would a person who's interested in alpha-synuclein be interested in iron? Maybe it's because we know that these areas of the brain are certainly susceptible to alpha-synuclein-related pathology. So it turns out that a lot of people, a lot of scientists have thought about it. And it turns out that you can use a biomarker. Remember what a biomarker is? Quantitative measure of iron. You can do that. And so here's an example of one way that we have done it. It's an imaging method. You can actually quantitate how much iron is in a part of the brain, which is kind of attractive if you wanted to follow how a biomarker of iron over time. So there's a lot of people that are interested in iron. And there's been a number of papers, and if you really want to get in the weeds, I'm happy to give you those references that you can talk about it. But it turns out that people think that iron is related to alpha-synuclein aggregation, and especially diseases like Parkinson's disease and maybe others. So the question is, can you change the way the brain deals with iron? Can you change the way the interaction between iron and neurodegeneration happens? Oop, so I had other slides. Are the other slides? Well, I'll have to describe these slides for you. I sent an update this morning, but they didn't get put in. So I'm really glad I'm going to describe this for you and not use bar charts. So it turns out there's a compound that some scientists have affectionately termed PBT434. And it's related to a company called Prana who looked at this. And it turns out that their compound, they think, can change the way the brain handles iron, and it changes the way iron effluxes. And so they've done studies in mice or rodents, and they've given these rodents diseases like Parkinson's and MSA. It turns out you can do that. And they gave this compound to these mice and rodents for a long time. And what they found is that the aggregation of alpha-synuclein improved. That is, it reduced the amount of aggregation of alpha-synuclein or Lewy bodies. And the places in the brain where it reduced were the substantia nigra, where it was also the brainstem area, which was very interesting. And so now and on top of that, the function of those rodents improved as well. That is, they were able to walk better, and they were able to move more effectively. Even some of their cognition improved. Yes, people look at rodent cognition. That's a real thing. So now PBT434 is going to potentially be a target for disease modification of MSA. And so I think it'd be exciting to look in the future as to could this compound be used to change the way the disease progresses. So that's a lightning round for clinical trials. What can you do? And I wanted to give you a personal story of a way of just what happened to me as a scientist and as a clinician that I think I want to encourage you to do. So when I came to Vanderbilt 8 years ago, I had two families that I took care of that really encouraged me as a scientist and as a clinician to start clinical trials work. And if it wasn't for them to be persistent, to be helpful, to be interactive with me, I would never have gotten into clinical trials, because it's an art, and it takes a lot of time to learn, and it takes a lot of resources to get started. So I would say, if you're a patient or a carer of a patient, find a person who is close to you, who's interested, and work with them. These things don't happen in silos anymore. There's so much important work that happens in the community and with academic, in my case, academic medical centers, that we couldn't do without you. We do focus groups to ask questions: what's important for you? What are the treatments you think you need? Without those focus groups, we wouldn't know how to position some of the treatment trials. Be a part of those. Run them if you want to. But it's important to do that. And I would say make your voice heard. I'm a strong advocate of talking to your senators, your congressmen, congresswomen about advocating for research dollars. It turns out that matters. And if you do that, you can get people to commit to resources to these kind of things. And this is my family. This is my wife and my 2 boys, and that's my wife's grandmother, who has MSA, and she was diagnosed 2 years ago. And it was quite, I got a phone call because I'm a neurologist in the family. Everyone calls me with all their neurologic problems. So I got a phone call, and she was having a postprandial aphasia, meaning after she ate her food, she had a hard time talking. And she had gone to the ER for a stroke, and they didn't find anything. And so it turns out she had autonomic dysfunction. So this is a personal thing for me. It's personal for you. But hopefully this gives you some hope and gives you some ideas of where we're going to go forward. All right? Thank you.